Henry? Hear me? This is Gina at BMH. I'm going to be sharing my screen for the presentation. I'm just wondering if I can be allowed to share, that if that permission can be set up.
Yep, Gina, we'll get that changed over right now. Thank you.
Great, thank you so much.
Rebecca, do you need to do a sound check before we get started?
No, I can hear all of you guys well. As long as you can hear me, then I'm good.
Okay, we're all set. Thank you. For those who are unable to see the screen, we will get started at 9:35 this morning. Gina, I don't see Dr. Blofson or Dr. McClarney in the list of attendees. Are they using another name to use a camera?
Sorry, I think you were just calling for me. Yes, they're just jumping on right now.
Okay, great. Thank you.
Okay.
All right, good morning. Rebecca, are you here?
Come over here.
Yes, I'm here.
Great. I don't see any of the board members. Tom, Sarah, Dave, here you go.
Rebecca, we have
I'm
an
here.
echo now.
And do we have
Morning,
teach
Chairman.
out? Good morning, Tom. Is Sarah here? Okay. And who do we have here from Brattleboro?
David Sandville's here, but I can't make my mic work for this meeting for some reason.
And Tony and I are on together.
Great. And is that it, Dr. McClarney from Brattleboro, yourself, Dr. Bluffson, and Mr. Sandville?
Yes, it is.
Yes, it is.
Great, okay. Then I'll call to order the Green Mountain Care Board's hearing. Rebecca, we can go on the record.
On the record.
Right. Good morning. Today is August 14th. It's our final day of budget hearings. I'll call to order our hearing. First up, we have the Brattleboro Memorial Hospital team to present their budget. I will ask our counsel, Ms. Korelman, to swear in the witnesses. Dr. McClarney, Dr. Bluffson, and Mr. Sandville, thank you for being here. After she reads the oath, please affirm it and state your name for the record.
All right, thank you very much, Chair Foster. So I will read the oath. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
I do, Elizabeth McClarney.
Yes, I do, Tony Bluffson.
I do, David Sandville.
Great, thank you all. I'll turn it to you, Drs. McClarney and Bluffson, for any opening remarks or presentation on your budget you may have. And we're trying to keep it around 30 minutes, although some hospitals are going more around 45. And if that's what you need, that's what you need.
All right, we'll try and keep it within the time limit. Good morning. Good morning. Thank you for having us. I am Elizabeth McClarney. I'm an orthopedic surgeon who has been at Brattleboro Memorial Hospital for 26 years. I became the co-acting CEO in October of 25.
I am Tony Bluffson. I'm a family physician. I've been the acting co-CEO the same amount of time since October, and also been in Brattleboro for 26 years.
I'm David Sandville. I've been here on site as an advisor consultant since October. In December, I took over CFO duties as well. Good to be here again.
We also, I believe, have Chloe Leary, who is our chair of our board, on just for support.
Right.
Go ahead.
So, slide. Well, thank you all for the opportunity to come back. I think last time we were here in January, and we've a lot has happened since then too. Brattleboro Hospital is one of the largest employers in Windham County. I've been here since 1904. It's at this time 600 employees and 450 full-time. I want to remind you, we are an independent, not-for-profit hospital, not critical access, not an affiliated, not with UVM or with Dartmouth. Formerly a Medicare dependent hospital, not having that status this year. We're licensed for 61 beds, but I want to point out that the average daily census is 19, so more in line with the critical access hospital. Also showing that it's a subsidiary. The hospital is a subsidiary of the Southern Vermont Health Services Corporation. That is the corporate structure that we have. Next.
So when we first took over, one of the first things that I did was try and figure out kind of what was happening. And I asked our then CFO to give me a profit and loss comparative history. In this, we have excluded what I call extraordinary offsets, things that we got because of COVID, et cetera. And when you look back, and if you actually go back to 2017, we have lost money every single year except for 2019. The losses have been mounting, but this is not a one-year issue. This is a multi-year issue.
Just to catch you folks up, since we last met in January with you, is FY25 had been projected at a much smaller loss by prior management. We finished the year, our audit took until May to complete, got approved by the board in June, which was actually a 3 or 4 month improvement over prior years. The bottom line for that audit on operations was approximately $16 million loss for the year. However, that was clouded by an ERTC reimbursement that came in from the pandemic. And so really, if you take that out, as Dr. McClarney referenced earlier, and measure really what's the financial production on operations, it's about a $23 million loss. The most notable key element of that was a $12 million adjustment unfavorable to adequately get our reserve levels to where they needed to be. At one point, probably about 7 years ago, our reserve levels were about 80% of 80+% of our accounts receivable. And that dwindled over the years down to 28%, which is woefully inadequate. So we worked with our auditors to retest the AR and to determine an appropriate reserve level. And that is the crux of the $12 million additional hit on operations. The original budget was approximately a $500,000 budget, so pretty far off. Our AR and our accounts payable were inflated, causing the organization to have to withdraw funds from board designated and other investments. And then if we go to the next slide, please, Gina. One back, please. And then FY 2026. So got here in October. The Green Mountain Care Board asked for a revised and realistic budget. We feverishly worked for 3 or 4 weeks to produce a budget from scratch. The budget came out at a $14.5 million operating loss. At the time, that really was shocking to a lot of people internally and externally. But I think the final closure of FY25, our run rate over time, and where we are this very day validates that estimate as who we were at the end of November looking forward. We're projecting about a $9.5 million loss, which is a $5 million improvement over budget. And volume has improved in the outpatient setting, meaning clinic and outpatient hospital. And AR is improving as and our accounts payable are now under 60 days. At the time when I came in here in October, I think we were 7 or 8 provider tax payments behind. We are happy to say that we are current in that regard.
So when we took over in the very beginning of fiscal year 2026, and Tony and I were somewhat conscripted into this role, the first thing we did was take a deep breath. And in my notebook, I wrote down 3 words: transparency, expectations, and accountability. And these words were written down because this is what our organization needed. This is the approach we needed to take. People needed to know exactly what was going on. Expectations needed to be set, and then people need to be held accountable.
So using that framework, we had to figure out where the emphasis was going to be. Clearly on managing costs, improving access, which is some numbers we'll get to later on, continuing to have quality care for patients that couldn't be lost sight of. Talking on strategic priorities for a moment, there was so much ripe for change and improvement. We had to triage that. We had to prioritize what we were going to work on first and prioritize, and then go down that list, while maintaining the culture of Brattleboro with some adjustments, but maintaining why people were here and been working here for decades. Slides.
So breaking this down, and again, most of our slides today are kind of highlights or key points. None of us have enough time to address all of the areas that have been looked at, worked on, and evaluated. But these are the primary areas that we have focused on from really top to bottom in the organization. We've reviewed charging and documentation skills and effectiveness. We have been ramping up our efforts to improve the revenue cycle, which would be, scheduling, registering, pre-authorizing, billing, collections, financial assistance, all of that. We are completing complete charge master review and making sure all the proper CPT and HCPCS codes are on there, et cetera. Reimbursement, looking at the existing contracts that we have, making sure that we're being paid for the work that we're legitimately doing. We have found areas where we were not getting credit or giving ourselves credit for the work that we were doing. We've been working since February in earnest to clean up our financial systems, which not only includes the revenue cycle, but more importantly for Green Mountain Care Board reporting and Medicare cost reporting and 990s, making sure that our general ledger, the chart of accounts, the mapping, all of that is up to speed. I would say that we're generally up to speed for internal purposes. We're still struggling with converting our internal definitions into definitions that work for Medicare or Green Mountain Care Board or whomever. Spent an exorbitant amount of time working on our bond default. Was surprised to learn that we had been in default since 2022. And so worked with our bond bank, and we have negotiated a forbearance, and that is actually quite favorable for Brattleboro given our current situation. But we're waiting on the attorneys to finish all the legalese, and we have not actually closed on that forbearance. Reporting kind of goes along with the system optimization, developing the ability to report internally and externally in a timely fashion. Again, we're still struggling with some of the external applications in that regard. Working on expense management. Essentially, we have touched every area of or category of expense, although we have not gotten through every single line item. Working to staff to volume, working on contract management, not only who is authorized to sign off on those things, but are we getting what was agreed upon, and are we getting the best deal? ELT spent a great deal of time working on labor negotiations, which that began in last fall in September, October. And we had to put that on hold to work on some other issues, but that was recently completed. And working on governance and authorizations and the like. And we have begun a service line review, which is going by department by department. What are our costs? Why do we have those costs? What are the revenues? Are we getting all of the revenue? Is our billing processes up to speed? Super deep dive, one department at a time.
So we talk about service line, there's the financial part, but there's also the workforce part. We had several concerns because it's a small independent hospital. We have departments of single clinicians. This year, there were several issues came up. Oncology, we spoke about earlier when we were talking with the board, that our single oncologist had been pulled back by Dartmouth after many years. So there's been an enormous amount of work, helped by AHS actually, to find a replacement and to continue oncology here. We just about finished an agreement with UVM to be able to continue that for the local community. The birthing center issue is probably quite well known to you as well as the rest of the state. That continues to be a significant concern of how we're going to continue to with our birthing unit, which includes coverage for pediatrics. We have to outsource pediatric locums to cover the unit. Anesthesia and emergency departments were both outsourced contracts that finished with the old contracts. This year we have a new anesthesia group that came in for it. It was adjusting that, as well as a new emergency department group that contract, which was started in July, which is going extremely well. And you'll see some numbers about that. But that was also everything new to adjust to this year. In single lines, cardiology, urology, both single clinician departments, both retiring. And we've been working on how that's going to be succession planning for their turning in. We're pretty much have a deal on both of those to continue. Primary care is always a good turnover. As you know, the people are not working 26 years in the same place anymore. The average tenure is more like 3 to 5 years. To not mention here is gastroenterology and neurology, also single clinician service lines that we have to keep mindful of. Next.
Just to briefly go over, and again, happy to expound on this at a later point, but we've been quantifying some of all of the areas that we have improved. And so when we think about how we get to where we need to go, we're talking about cost, access, and quality. And we want to maintain our quality, as Dr. Blosson said earlier. We want to cut our costs, and we want to improve access. These are the expense side of, and these are just highlights and certainly not an all-inclusive list, but our annual and ongoing efforts to cut costs come to about $3.3 million a year ongoing, assume nothing changes. We had a huge cost avoidance in the negotiation of the bond default, which avoided about $7.5 million in additional costs going forward for 15 years approximately. We've looked at really, right now we were in the midst of looking at every non-salary, non-labor cost at a micro level between invoicing, contract terms, and so I have a list here, and I'm not going to go down it in the interest of time, but we've put $3.3 million on the books year to year going forward, and a significant portion of that will be recognized in FY26. So some things were recognized in February, March, April, May, June, et cetera. Right up to our recently reduction in force of about $840,000 in salary and benefits, not including the attrition that we've managed starting last fall till current. Also under cost, these look kind of like revenue, but at the end of the day, there's cost to do operations and there's cost to the system. And as we improve revenue, that improves our cost per unit delivery. And so it's a different type of cost, but it's important nonetheless. We expect that we have found about $4.2 million going forward that will be repeatable year to year to go on the bottom line. We were able to obtain a $1 million stabilization grant, which is largely paying for the specialized help that we are bringing in to affect these changes and improvements. And we've recovered about $1 million that happened previously that we were able to regenerate and get out. So some significant improvements in our systems in that regard.
There is a lot of interdigitation of the cost, access, and quality, so they're not mutually exclusive. One of the things that David just showed on the slide was the money that we have recouped with our acute to acute transfers. But that also increases our access. That lets our patients who need more acute care somewhere else return to us. So then they're local, their family can visit them here. So that increases our access. We've increased our outpatient clinic revenues by about 30%. Part of that is from revenue improvements, but a big part of it is from increasing the access. We have instituted a culture of saying yes. When people need to come in, we say yes. We've increased our productivity. And we have also decreased our no-show rate by half. So that was a big problem for us. So we had decreased that by half, and now we expect to decrease it further because we have just implemented a texting for appointment reminders in place.
I want to add in here about the productivity. Last year, Blue Mountain Care Board pointed out to us that 67% of our clinicians were below the 25th percentile productivity. Can we come back this year and say 67% are above 25th percentile for productivity?
This just is another example of access. So while our emergency department visits have remained steady, if you look at the top graph, if you look at the bottom graph, you see the trending downward of patients who have left without being seen. So we don't want patients to come, get discouraged by the wait time, and then leave. And the significant improvement that we can see in the slide increases access for patients.
Next slide is going to go back to, it's a busy slide, but what's going on obviously is that we need to keep on the quality. We continue to maintain excellence for patients while at the same time putting in all these changes and improvements. On this one, on the left column on the quality, I'm just going to point out the zero harm, because those are a lot of zeros there, and it's quite impressive to be able to take care of that. And
it has been so important to us to maintain the quality of care that we have given to our patients in our community. There are a lot of things that we do that are unreimbursed. An example of that is our mobile integrated health program, our MIH program. That is where we partner with our local Rescue Inc., which is our local EMS service. And we partner for them to go into the home to care for patients and their families. We currently do it for our total joint patients, our patients with COPD, and our patients with CHF. This has decreased our readmission rate and our emergency department revisit rate by 20 to 30%.
I think it should be. I think it should be noted that not only do we not get paid for MIH, we also pay for it. So it's about a $400,000 a year expense, and that reduces our inpatient and outpatient revenue significantly, far more than what we're even investing in that program.
next one, Gina. This is again a slide that, despite all the focus we've had to do on financial instability, we've really been able to maintain an excellence in care, particularly drawing attention to the first line, a surgical site infection rate less than 1%. Gone.
So one of the other things we've done is we've moved our orthopedic patients to same-day joint replacements. Actually, as I was looking at the slide this morning, I realized there's no way 60% is accurate, as I did 5 joints on Wednesday and they all went home. So I reached out and just got actually an update that actually 73% of our patients in July and 83% of our patients in August are projected to go home same day.
One of the interesting things about that matter is that when I got here and I looked at the significant change in inpatient days and the increase in same-day discharges, I advised the group here that this is great. We're reducing risk to patients, keeping them out of the hospital environment, reducing what we bill. All of that is very good. Unfortunately, we saved everybody else money, and we didn't get anything for doing the right thing. So I just bring that to your attention that really, if we're saving, Blue Cross or whomever, a fair amount of money, it would have been nice to have shared in that upside mutually, but we did not do that here.
But David, we are saving the general Vermont healthcare system money.
Yes, we are.
The slide showing a continuation of what the point of them with continued quality while working on that financial. The one on the right, the Excellence in Innovation Award, was for the mobile integrated health project that Elizabeth was talking about. Next. Another project. This is a grant for colorectal screening, and as you can see, the line just keeps going up. Now colorectal screening is getting up to 75%. We start around 60, while the national average remains between 59 and 65. Next slide. So when we kind of all arrived in October,
we realized that there were really no organizational or strategic priorities. So we all kind of got in a room, executive leadership, and hammered out some basic tenets that we would operate on for the foreseeable future. And obviously, I'm not going to go down every bullet point here, but happy to discuss anything that you have questions about. The most obvious was stabilize finances and make this organizational viable. The second thing was to strengthen operations and making sure that operations are aligned with patient needs, safety, quality, but also lend themselves to a positive financial outcome. We're looking at how to invest in our workforce, which clearly salaries, wages, benefits, but also development and other aspects of engagement, recruitment, retention. And lastly, is to make sure that we were protecting the access and quality and then taking steps to improve it going into the future. It's a lot easier to just slash and burn, but our concern was that that would not lead to an ongoing sustainability situation for Brattleboro. So we've tried to be maybe more skillful and surgical in our approach to maintain the positives that were going on here and then working on the things that needed improvement.
It's really important as we work on our financial stabilization that we do not lose the quality of care that we provide to patients. In one of my other hats, I've been the long-term chair of our Patient Quality Safety Committee. So we continue to focus on quality while we're doing all these other things. We have a culture of safety survey coming up this fall. We want to continue to maintain our zero preventable harm events. And we have a very robust workplace violence prevention. This dovetails with our workforce protection. We have instituted an ED weapons detection system, and every member, every employee undergoes evade training.
We've got a grant for hypertension improvement, and that project is going out throughout the primary care. With the one care closing down, we moved to another ACO. We joined Belong Healthcare, a different ACO, which has the very similar quality measures. So it's mammograms and immunizations and colorectal screening and annual wellness visits. So we're continuing to be able to track those and continue to improve. We are just putting the attestation for level 3 patient-centered medical home, and there was no audit asked for. That's been level 3, which is the highest one for many years.
And that's for all of our primary care.
All primary care sites. Yeah.
A little bit more detail on the financial stabilization. Again, working doggedly on improving our financial systems, both the revenue cycle as well as financial reporting, and really working on access, as we've referenced earlier, improving acute to acute and getting patients back to our community for the care they need. Again, we're looking at literally every area of expense. No stone is going to be left unturned. We probably have about another 4 to 6 months of really intensive work. And it should be noted that any improvements that we've done in revenue, access, cost, we're putting it back on the schedule to review in a couple months to make sure that we're seeing the desired result or to tweak to improve the results further. Every vendor contract we have is on the table for review and discussion. We've tightened up the approval process. We're really getting tight on what market commensurate rates and terms should be. If there was one theme that has been recurrent here at BMH in my time here is that we are not market commensurate. And so great effort is being made to bring ourselves into line with what industry standard expense, revenue, et cetera, should be. And we're working doggedly on that.
So I'm going to remind everybody that we are an independent hospital. We are not affiliated with a larger medical system. We are not a critical access hospital. So in order to continue to provide the care that we need to provide to our patients in our community, it is vitally important that we engage in transformation. And one of the things in our AHS transformation plan is developing partnerships. And on here, we can talk a little bit about that. One of our major partnerships is with the New England Collaborative. We were actually a founding member. Through that, we participate in group purchasing organization, which has actually saved us in, as you can see here, in fiscal year 25, 1.2 million, and projected in fiscal year 26 to be $1.3 million. We also participate in their benefits program. So we are kind of crowdsourcing that with everybody contributing, as well as we do education through the New England Collaborative. They came and did a training session for our leaders, which was wonderfully attended. And we continue to work on more projects with them, including shared services like with IT and HR.
Another partnership has been with Blue Water. They are a group that I found when we lost our previous emergency room contract. Blue Water came in July 1st and has been an amazing partner. They are in 11 different hospitals in northern New England. There'll be a slide that you've seen about, well, coming up about how the improvements they've been making, and they've been an excellent partner to work with.
We work with UVM. Currently, we do all of our pathology through UVM, some of our lab work through UVM, and we are working and almost finalized a partnership for providing oncology services with the loss of our oncologist.
With Brattleboro Retreat, we have shared services. We have IT shared services specifically in cybersecurity. We have been working with them, taking care of their laboratory tests for them, with a new hub being built to make that, facilitate that more easily. But also a collaboration where we get supplied a part-time therapist, psychiatrist actually in the ER, as well as inpatients.
We work with Dartmouth. They have been our long-term partner for providing radiology services. And we do a number of telemedicine partnerships with Dartmouth as well.
We have a partnership with Bay State under cardiology, helping as a single cardiologist here, it becomes a lot. So helping with the EKGs and also echoes, doing the reads for those.
And then I think Tony mentioned earlier, but I'll re-mention that we have our anesthesia outsourced to integrative anesthesia partners, solutions, I guess they're called, and they provide us with our anesthetists.
Next slide.
So it's important to focus on our workforce. We cannot exist as a hospital without our workforce, and they're vitally important to us. We have significantly reduced our traveler and contract labor dependence. We're working on workforce retention, we're working on education of our workforce, and we're working on staff engagement.
Next. A graphic to show how contract labor has been declining, replaced by more permanent workers, especially the part on the right, which is the total number, cut almost in half over the year for the number of contract labor. Pointing out that contract labor is not just nurses, it affects many departments. Radiology, lab, people need to be replaced. If we don't have permanent workers, get contract laborers to keep all the departments going.
I drew the short straw on discussing key risks, and I'm sure you've heard many of these. We have far more that keep us up at night than can be fit in these 9 boxes, but we tried to prioritize and just bring to you the things that were most concerning. The first under workforce risk is physician retirements, which has been discussed briefly earlier. Labor relations, whether that's the union or non-unionized employees, is a constant concern, especially with the competition from unregulated environments and trying to recruit and retain. And obviously, what you've heard everywhere for many years is our aging workforce. Relative to regulatory risks, one big beautiful bill, we don't all fully understand the impact of what's coming down the line. We have other more regional or statewide concerns coming down the road, reference-based pricing being probably the highlight of that. Dr. McClarney and Dr. Blofson made me remove Green Mountain Care Board from the third box down the bottom. But we have to pay attention to what you folks are doing, what AHS is doing, what the Medicaid program itself is doing. So that's something that we have to try to keep our eye on, even while we have our heads down, focusing on these very base, foundational, operational, and financial issues. Financial risks, inflation, most notably in salaries and benefits. Our self-insured plan is running hot for really the last 2 years. And we've made some benefit adjustments effective January 1st, but that's only mitigating it. It's not solving that problem. And then lastly, declining commercial insurance and payer mix. So Medicare, Medicaid, not paying cost, commercials is where the margin comes from, and having less and less of that business over time.
So we need to look at our strategic opportunities. Expanding our strategic partnerships is vitally important. We have done a lot of regionalization initiatives, as you've heard. As recommended by Oliver Wyman, we've increased our acute to acute transfers, and we continue to explore the feasibility of both critical access hospital designation and FQHC opportunities.
So this is a visual reminder of what we keep saying, that there has to be the financial discipline that's really been the key priority for this year. You've seen some of the results of that. The strategic partnerships that either need to be strengthened or reaching out for new ones. Mentioned the UVM and oncology before. Workforce is critical as we go forward with this. It's everything we've said before, including what's going to happen now with the birthing center for workforce and financing to try to keep that in the community. The community support has been extraordinary in trying to help us keep the birthing center open. We need to continue to expand access to care. I'm a family doc. Doing primary care is, to me, what it's all about in healthcare. We are improved, but there's still more to go. We could still do better. Never want to hear someone calling and say, oh, I had to wait to get an appointment. We want to be able to have people see them when they need to be seen. So that'll continue to be an enormous focus for us. Last one.
Just some takeaways that we'd like you to keep in mind as we go forward and into the future. Essentially, with one exception, all of senior leadership, executive leadership is new and here under 2 years. There have been some key transitions, and we are working diligently to not only right our reputation, but our effectiveness as a provider in the region. So Elizabeth coming in and talking about setting expectations, being accountable, being transparent, that is part of our new leadership model. As a finance guy and an operations guy, I'm really focused on getting us market commensurate in every way. Volume, staffing to volume, salaries, benefits, non-labor costs. We've been working to improve the oversight and effectiveness of the governance structure here. We are every month making significant progress, reporting internally and externally. We've made significant progress on our revenue cycle improvements, and that will continue for several months. And we will continue to finish up all of our service line reviews for literally every single line of business offered by this institution. And lastly, we're going to maximize our ability to collaborate, partner, and work with other entities for mutual benefit and for the benefit of our communities. Appreciate your time, and please let us know if what we can answer for you this morning.
All right, thank you very much. I'll start with Member Walsh.
Good morning. Thanks for being here with us, and thanks for all the work you're doing. I've got just a few questions. I wanted to start with your expense management, and I'm trying to sort out what's already in the run rate and what comes next. As I was looking through the material you sent and listening this morning, it sounds like there were $3.3 million in annual ongoing cost improvements last year, and your 26 expenses projected are about the same as your 27 budget. So I'm wondering if you could help me understand the 3.3 million ongoing. Is that already reflected in what you expected to finish this year, or is it actually ongoing into 2027?
That is, so the 3.3 million, there will be, and I could give that amount just not off the top of my head. We have realized portions of that $3.3 million in FY26. Some of them were found in February, April, whenever. And then if they are ongoing, I calculated the annual value of that and put it in the ongoing column because that will be an annual benefit.
Do you have an estimate of what that came out to, Mr. Sandville? What that
I
portion
believe off the top of my head, we have realized approximately $900,000 year to date in FY26, like kind of projected through September 30th.
Okay. Great. That's helpful. Then in the slides, I didn't get the number on the slide, but the one that was labeled costs, there was 4.2 million going forward, and about half of that, the 2.2 was improved access and volume. And I just wanted to understand how you're seeing improved access and volume as cost reduction.
Yeah, so there's two types of costs we talk about at Green Mountain Care Board, right? We talk about what it costs us to operate the facility, but then we talk about the cost to the system, patients, employers, insurers, right? The greater good, for lack of a better term. And so the way I look at financials, which may or may not be normal, is if I can use a greater percentage of our overhead and fixed costs to provide more services without increasing operational costs for us, we are making a dent in our ongoing cost to the greater good going forward. So there were kind of two cost lines. First cost was operational expense, direct things that we could calculate. And the second are more revenue-oriented things that are reducing cost in the greater sense. Does that make sense?
It does, and thanks for clarifying. So there, if I've heard you correctly, and I'm following how you think of this, there's 3.3 million reduced in operating expense at Brattleboro, and about 900,000 of that is expected year to date, and the remainder would be going forward and been built into the 27 budget.
Yeah, all of those changes have been built into the 27 budget.
Okay. In the material that you sent to us, but not in the slides, there was some discussion about the 340B program and losses to Brattleboro from that. It's been hard with all hospitals in discussing that program and Act 55. The net effect after the cost of the pharmaceuticals and the revenue generated from it. So I don't want to try to go into that very deeply with you here, but what I'm wondering is how much of the 2.5 commercial increase that you're requesting is meant to fill the gap from the loss due to the 340B change?
So, so good question. So 340B is two portions. One is the contracted pharmacy retail relationship. And the second is our ability to purchase medications below AWP, below GPO pricing, et cetera. And so we lost that, and that ability to save on our purchase and acquisition costs, I believe, is about $1 million a year. So that went away. So if I'm going to overly simplify, I don't really build my budget this way, but to translate it, so every 1% of price increase nets me $1.1 million here, rounding off. So 1% covers the 340B loss on cost savings. On the retail side, I believe we generated about $1.5 million in retail benefit for 340B. So that would be your second percentage point in price increase. I'm overly simplifying it, but I think that's pretty illustrative.
Okay, I appreciate you walking me through it, and so thanks for simplifying and walking me through it. I can start to understand. So I want to switch next to the birthing center. And I'm just wondering, from you, do you see a realistic path to keeping the center open? And if there is, what would have to change, and how soon?
I'll let the doctor start, and then I'll add color commentation.
I'll start with that. Realistic is a hard word. To be honest, there's so much emotion around closing a birthing unit, and we definitely would like to keep it open if at all possible. We set some conditions for success for being able to keep it open. One is financially being able to sustain it. As you noticed, and you pointed out, and I'm kind of reading into one of your questions to Mr. Sandville, you said, well, we're projecting a $9 million loss this year. We're putting in for a $7 million loss for next year. And you had said you had $3.3 million in savings. That doesn't add up. Well, we also had to negotiate significant wage increases with our union brethren and employees. And so that's costing us about $2.6 million. So that's adding to our costs. So that, coupled with a $5 million loss on a birthing unit, is not sustainable. We need to recover financially. We can't do it overnight. And we know this is a staged process. So we have brought the amount that we're losing down from year to year. And we're really hoping going forward that in fiscal year 28, we can present a balanced budget. So this is a very long conversation, sorry. But so financially, the birthing center is difficult to sustain. Then the second thing is workforce. We need to maintain our workforce. We need pediatric coverage. We have no pediatricians that are employed by Brattleboro Memorial Hospital, so we have to outsource that. We have currently one practicing obstetrician employed by Brattleboro Memorial Hospital, so we are supplementing that with locums and per diems and things like that. And then we also have to maintain our nurse midwife workforce, and then all of our other workforce, our OB nurses, et cetera. So workforce is an issue as well. To be able to maintain and keep our birthing center open, we would need an infusion of money, cash. The board has said that if we could raise $3.8 million, then we could then stomach the rest of the loss. So cash, maintaining our workforce, And of course, maintaining the excellent quality that currently is given in the birthing center to our patients.
To add to that, that would be maintaining the loss for a year until there's time for the legislature or other outside institutions to be able to change reimbursement. So what the hope would be was to find a way to sustain this for this year into the next legislative session or Medicaid, DEVA, AHS, all the people we've been talking to, changing how rural obstetrical care is reimbursed to make it sustainable in this country. As you know, over half the rural hospitals in this country do not do obstetrics.
Yeah.
There's
And
a reason.
I'll piggyback on the on that in that this was one of the service lines that we did a deep dive on, and the amount of data and doctors can correct me. Nobody in this organization has seen that level of data on any service line in decades. Super thoughtful, highly vetted, and part of that process is not only measuring what is it, is also determining what it could be. And in my world, as I look at that, there with operational efficiencies, because there's something that can be done internally. With operational efficiencies, I think we can get to an improvement of, say, $500,000 a year. But in FY27 terms, that leaves us with a $4.5 to $4.7 million subsidy still. And all of the workflows and implementation that would be required for the clinical folks to make the magic happen is a cost that we're not operating with currently. So and one of the things that I've expressed in various settings here, leadership meetings and whatnot, is that in other organizations that I've been in who are also small rural facilities, had the advantage of critical access hospital reimbursement. One of the things was that we had such strong performance in other departments that we could float what we viewed as a highly necessary, important service for the community. In fact, we were at Gifford. We were floating a hospital-based nursing home and the birthing center 20 years ago. So we don't have the infrastructure in the rest of the facility to get us there and carry that.
I understand. You're facing a lot of headwinds. And again, I want to just thank you for stepping in and stepping up when the need was noticed. And I understand that this is a moment in time and I'm asking you questions and you're on the spot. And these things do take time, so they may evolve. I'm not trying to pin you down. But as I was listening, if I heard you correctly, to achieve a balanced budget for 2028, there needs to be an infusion of money to cover expenses at the birthing center, and there needs to be a change in reimbursement. That without those things, the birthing center would need to close in order to have a balanced budget by 2028.
So I'm going to jump in and the doctors can correct me.
Yeah,
There's two aspects, and this is terribly ironic that the finance and operations guy brings this up in meetings. So the lowest common denominator in our birthing center situation is really not money. It's coverage. Now, coverage costs money. We all understand that. But as Dr. McClarney referenced, no pediatric coverage for the weekend. We're on diversion. Doesn't matter if we're making or losing money. If our OB provider complement gets too small, it's an unsatisfying lifestyle. And you've seen this with other hospitals in this state where they're down to 1.5 OB providers, and that's an issue. So we've got the big elephant in the room, which is, the $4 to $5 million problem. And we can make a dent in it, but that's it. And then the other side of it is the logistics of having proper coverage, maintaining quality and appropriate access. But they're equally important. And in my opinion, almost equally difficult to solve.
Yeah, I understand and appreciate you walking us through it. And I saw that on the slides when you were talking about the pediatric coverage and the other coverage issues. I'm sure there'll be other board members will have more questions, but I'd like to switch topics a little bit. Well, before asking more questions, you mentioned maintaining quality, and I just have written on my notes to make sure that I acknowledge the tremendously positive quality measures that you shared with us. Those are hard to achieve in the best of times. And to be doing that under the financial strain that you're under is quite remarkable. In my experience, well-run places do find a way to view quality, safety, reliability as part of their cost management philosophy and strategy. They can complement each other. And I think that you're seeing what you're sharing is just showing how improvement can cut across all those areas. And thank you for what you're doing there. You also mentioned the other areas floating or cross subsidizing. Could you describe more and your difficulty doing that at Brattleboro right now? Because you're not dealing with one department having difficulty, it's the whole place. In the material that you provided us, there was some discussion of a primary care partnership or an FQHC partnership. And I'm wondering how that, if you could say a little bit more about your thinking there and what happens with or without that coming together. Like how critical a piece is that in your thinking?
I'm going to start off. So we've been in discussions and actually been negotiations about a federally qualified health center partnership or a takeover or a lookalike for several years, both with North Star, Rutland, North Star again. It was determined some years ago that Brattleboro by itself would not qualify because of the numbers just wouldn't allow it to be a FQHC on its own. That's why I've been looking in consort with others. What's come of it so far is that the Wyndham Dental Center, which we've started and have been supporting financially through rent agreements, through supporting dentists, that's now being taken over by North Star, the federal qualified health center. So that's going to take that expense off our plates. The broader one of the primary care has been a long journey that we've gotten close at different times, but it's just not able to make it work. What's happening right now is with the Rural Transformation Grant, we put in for a grant to explore again. It's to step back and look at what does the community need for primary care? Is that going to be coming from our hospital, from BMH, or is that going to come through a different system such as an FQHC? We were moving ahead in those negotiations early with North Star without that kind of vision behind it. What's going to be best for this community? So now obtaining that grant and using that expertise, we could look at what's the best way to move forward with our 3 primary care sites. It could make a significant financial difference to be at FQHC. As you know, the reimbursement changed dramatically. So the hope right now is to get that grant, work with that partner in the exploration of how that best works for our area.
Great. I appreciate that and understand the focus that you're trying to bring to this work of making sure you're understanding the community need and addressing that in the best way possible. I guess my last question just kind of builds on that. There was also a discussion of critical access status. And could you also bring me up to speed on where things are with that and how that may pertain to the budget next year.
You guys mind if I take a crack at that first?
Sure, even though it's my favorite subject,
You're gonna
David.
I
you
know it is. I've converted her. Um, so this is a long shot. When I first got here and dropped that concept, it was very hard for people to realize how small, inpatient-wise, Brattleboro had become. But we, on paper, qualify. So what's your average daily census? What services do you offer, et cetera, et cetera? Do you meet the conditions of participation? The answer is yes. And so that was a little bit of a difficult pill to swallow, that life had changed that much. The problem we have is that the governor's exemption, which is how most of the CHs became CHs in Vermont, New Hampshire, Maine, et cetera, that expired many years ago. And so the mileage requirements between organizations thwarts us a bit. However, I did some research several months ago and identified, I think, 14 critical access hospitals nationwide who were approved in the last few years since the governor's exemption, who do not meet the mileage criteria, same as us. So we could kind of all read between the lines and understand how that happens. And so we are trying to figure out a way to bring that to pass, or at least have the option to consider that. It won't solve all of our problems. It won't put us on easy street, but it will allow us to focus on, quality and engagement and safety and cost and all of that. So it can be used very effectively for the greater good.
I'd like to also just point out, because this is my favorite
Please,
topic, that
please.
all but one of the critical access hospitals in Vermont do not meet the criteria defined. And in order to become a critical access hospital, it's my understanding from all the research that we have done is that it would really literally take an act of Congress. So we have been in touch with our legislators and have brought this up.
Right. All three of our Washington delegation, they're aware of it.
Those are all the questions that I have this morning. Thank you very much for being here, and thank you for the work you're doing.
Thank you, Mr. Walsh.
Thanks.
Thank you.
Member Teachout?
Great, thank you. Good morning. And thank you for your presentation. I had a few questions. You mentioned at the end of your presentation that you were changing hospital governance. I really wanted to learn more about what steps you're taking to improve your hospital governance and oversight.
I think the biggest area, and this contributed to our current situation that we're in the midst of, is ensuring that there was more accountability for management to give the board the tools, measures, and information they need to effectively govern us. And so we've spent a great amount of time formalizing standardized reporting. It still takes us about 2 weeks longer to close a month than I'm used to, but we're closing it with good quality. We're just trying to take the clunkiness and inefficiency out of that reporting structure still, but they are getting consistently measured reports, investment subcommittee, finance committee, board. The membership on all of those areas is not necessarily one-to-one, and they all have different responsibilities within our overall performance. And so we are also cross-pollinating that information. It's not like finance committee is the only one who gets certain finance information. It's going on the consent agenda at the board, but it's also being shared with the investment subcommittee, who's developing our strategy for investments. They should know how we're performing operationally, what cash needs might be. So we're just at probably the best thing we've done so far is just cross-pollinate and provide consistent, repeatable, predictable reporting.
I'd also like to add to that, if you don't mind, We've also made sure that the information is going the other direction to the employees. So there are robust financial reports to senior leadership and just leadership as a whole to be then shared with their departments.
Great, thank you. That sounds like important improvements to financial controls and accountability. Have you changed your board education or recruitment? And have you changed anything about, and I realize you don't have permanent CEOs, but CEO performance reviews and evaluations?
No.
I think we're approaching some transitional time in terms of CEOs. And I really think this is more a question for the board in terms of their education and the way that they're carrying out their evaluations.
Okay. Do you have a board member in attendance today?
Our board chair was here.
Chair
I saw
was there. I don't see it in one other. Chloe, if you're on, yep.
I'm
Chloe.
here.
Yeah,
Can you hear
yeah,
me
sure.
now?
Yes.
Yes.
Hi, this is Chloe Leary. I'm the chair of the board.
Great,
Sorry,
thank you.
Miss, are you guys for testimony from Miss Leary, Sarah?
No, I just wanted to know if they had a board member in attendance. So I think that's
Great.
an important part of board accountability.
Yeah.
Agreed.
Thanks.
Thank you.
Thank you. Appreciate you being here. Okay, I'll jump to some different questions. Is it possible that you'll regain your 340B status in FY27? And I had thought maybe perhaps you could do it through CAH designation, but that doesn't seem quite as likely, at least in the near term.
Yeah, so when we were realized that once we filed our Medicare cost report in February of 26 for FY25, and we're not going to make the mark, I went back and looked at how the ratios have been calculated, and we were right on the precipice for a number of years. So, and frankly, in looking at the trends that we're experiencing, movement of inpatient to outpatient for services, the expected closure of the OB unit, all of those things are unfavorable with regard to that calculation. A reduction of Medicaid, looming in the future, that funding that will take people off the rolls. All of those things are contributing the wrong way, so it is unlikely.
Okay. Thank you. I know that I believe that you are using a number of outside consultants to support your hospital's recovery. And this sort of leads into some of the questions about transformation, but are you asking them to consider solutions that may not be standard approaches across the country, such as, we know what the standard approaches are: increase commercial revenue and prices, from cut low margin services. Are there other approaches you're trying to do?
I'm actually the hair club president in that regard. I am a consultant in my current role, and I am unorthodox. So, and I know, I'll just tell this quick anecdote. The day I came down to do an assessment, high-level assessment of the organizational performance and health, I was driving Dr. Blossom crazy because he's like, "Hey, do you want financial reports?" I'm like, "Nope, don't need them." And he came in at lunchtime. "Are you sure you don't want some finance reports?" "Don't need them." And so interviewed however many people, probably close to 24, in over the course of 12 hours, board members, doctors, senior leaders, middle managers. And because the bottom line is, if you're doing the right things every day, the money takes care of itself. So if you have good employee engagement, you have good quality and safety, you have good access, you're doing those right things, I've not been in a place yet who did the right things where the financials didn't take care of themselves. It's not that we just leave it to themselves, but you know, that's, if you don't have the right foundational approach to begin with, to your point, then it's fabricated or forced and not sustainable.
I want to add on that we have brought in a number of consultants, true, a couple of whom were quite extraordinary, have converted to actually staying here and being permanent. Our human resources person brings an outside perspective from quite a number of jobs, CFO too, and a couple of other consultants, like the first one we brought in along with Mr. Samville to come up with that new budget last year, did his work, did the cost reports too, and it's gone. So we've been paring that down. That's a lot of that $1 million stabilization grant we talked about, was to stabilize us finances, bringing in these very knowledgeable and expensive individuals.
Okay.
I will add on to that though, that a lot of the work that we're doing is, so it's very specific to a project. We brought somebody in who spent 5 days doing everything lab, produced a report, some recommendations, reviewed it, out. Did the same thing with radiology. And the other thing is, we're also looking, when we have people come in and help, we're looking to do value-based work. So if you don't find anything for us, you don't get paid. If you find something for us, you share in it, and then we get that benefit ongoing. So trying to be cost and cash effective working through this.
Okay, that's helpful. Thank you. I also noticed you have a large number of ambitious rural health transformation projects requested. And I was hoping you could talk a little bit about your plan to manage all of these initiatives and continue the turnaround on a day-to-day basis. And specifically, I'd like to hear more about the Southeast Vermont Perinatal and Newborn Access Network requests that you have or are part of.
So as far as the project management piece, I brought in a project manager, facilitator with me, because we're running, as we sit here today, forgetting about grants for a moment, we're running anywhere from 28 to 35 improvement projects actively. Like they're meeting every week, every 2 weeks, they're doing real work. We also had a great resource who was being displaced, who went to school for project management. And so she's shadowing and handling some small projects so we can, again, be sustainable, right? The consultant leaves, we've got to be able to continue to manage improvement projects. So as depending on what we get out of this, we'll either be fine with the resources we have, but we did build project management costs into those grants to make sure that they're going to be effectively managed, which is what we're doing with the stabilization grant and the transformation grant that we received from AHS. We knocked that out in 2 or 3 months. So we're getting the work done, getting the deliverable done, move on to the next thing. Beyond that, I think the doctors have some comments about RHTP.
Okay.
In terms of the perinatal one, again, we need a project manager to drive that. Regionalization is vitally important. Right now, you need planning to be able to do that. You need to take the best care possible of our pregnant mothers in our area. And that's why we've requested the RHTP funding for that. It depends on what we receive in terms of what we're going to be able to do with it. But there are many great ideas. We have Dr. Tennant, our obstetrician, working with us, and she has a plethora of good ideas for how we can engage and bring more births into the area.
Remembering that it's the only birthing center currently in Southeast from Windsor and Windham counties. But right, Grace Cottages closed, Springfield closed, birthing center, Mount Scott does not do births.
I would also kind of add, I think it's an important nuance. And Dr. Blofson mentioned it with regard to the FQHC study that we submitted as an RHTP grant application, but also on the Southeast Vermont planning grant for OB. Those are not going to be done by us, and they are not going to be BMH specific. They are going to be structured as to what is the right solution for the area. Now, we are the fiscal agent, and we develop that, but we're going to bring in outside a physician leader that you're probably all familiar with, as well as an OB leader, OB/MD leader to come in and work with a project manager to do the right thing there and come up with the best possible solution for the region.
Okay, thank you for expanding on that. When will you know if you received the funding?
Do you want to take this, or do you want me to?
Well, the grants are supposed to start September 1st,
Yeah.
kind of down to the wire.
Okay. All right. I did notice that, so I was curious. So now I just want to transition a little bit more into the finance questions and your request for an increase in commercial prices. So in the pre-RFI questions, number 3, you gave information about the capital reserves, both at SVHSC and Brattleboro Memorial Hospital. Are these additive? Do you add those numbers together to get your total capital reserves?
I guess it depends on where we're being asked. So we had some specific questions asking for those reserve levels for both organizations. We provided that. If we talk about our bond covenant, really it's BMH specific, but functionally, right? And so there's what does the language say, but functionally, the purpose of SVHSC is BMH. So if we were to go into default, then the bank would have access to SVHSC's capital reserves as well.
Okay. And do they both count for your days cash on hand, or only the BMH capital?
We're only reporting on the monthlies to you folks. We report BMH if but we know obviously what both of them are combined and separate. So.
Okay. I did note that you said that you are, and I'm looking for your term. Actually, let me go back. You talked a little bit about your new reserve methodology.
Yes.
Can you just go a little bit deeper into that for me?
Yeah, and I don't think it's anything terribly unique. I guess it's unique to Brattleboro, but it is not unique in the industry. You survey at the close of every month the credit rating of your AR, so to speak, what you can expect from your outstanding receivables, how much you expect to go to bad debt, how much to be written off contractual loss, how much to go to free care, and you assess that and you build a reserve against it, because right now you just have a gross AR. And then as contractuals, bad debt write-offs, financial assistance write-offs happen, during the course of the month, it comes off those reserves, and then you reset them at the end of the next month, so that you know what your financial standing is in any given close.
Okay, so you're adopting industry standard approaches in this area.
Oh, absolutely. Yes.
Okay.
100%.
All right. Thank you. So I noted that you are talking about market commensurate measures. That's the term you used. The hospital has relatively high commercial prices. It ranked in the data I looked at 4th overall among Vermont hospitals. Imaging, for example, I think every single kind of imaging was over 500% of Medicare, according to the Green Mountain Care Board data. Are you planning to have market commensurate pricing as well in the future?
So the short answer is yes. The slightly longer answer would be this. On every facility I've worked at in the state of Vermont, I have brought to the Green Mountain Care Board and its predecessor notification that we're reducing our pricing. So, but I've got to get stable first here. I have to get predictable so that I understand the impact of, what I'm tinkering with. We're not there yet. We're getting closer, materially closer every month, but I need some clean run rate in the revenue cycle data, in our general ledger data, to say that if I were to right size all of our radiology pricing, how much gross revenue am I taking off the table based on our current payer mix? How much net revenue am I taking off the table? And, do I have to do this incrementally, or can I do big bang? When I was at Mount Scottney, we did big bang on radiology. We took over $3 million in gross charges off our radiology charges and didn't ask for any consideration relative to budgeting for that. That was just something we absorbed and went forward with. It was the right thing to do, so we did it.
Okay. And then I did know also that, for example, the maternity charges were extremely low. So that's also adding to some of the financial pressures in that area. I did want to ask about, you said in your narrative that you're requesting a 2.5% price increase for all payers and all services. So I'm assuming that's across the board.
Yes.
But then you also say this equates to a 0.85% increase in net reimbursement. And then despite this, commercial payers will pay less in FY27. Could you please explain that to me?
Yes. So if our prices which is gross revenue, goes up 2.5 and our average reimbursement rate is 33%, with our current run rate on payer mix, 2.5 times 0.33 is 0.8. So,
Okay.
So we will realize 0.8. I will tell you, I will admit to this publicly, that when we were developing those documents, our decomp file, which I'm sure you've gotten feedback is frankly a nightmare. We had not gotten through that whole thing yet. And so when it got produced, I said, well, my comments to the Green Mountain Care Board were going to be in aggregate. Commercial payers are going to pay less, but they're on an individual encounter basis. They're going to pay, they're going to pay 0.8% more. But then when the decomp finished out and we tested it and all that, it was like, well, no, I actually lied on half of that. In aggregate, they will pay more next year, not only on an encounter basis, but also in aggregate. So my bad.
Okay, appreciate the clarification. And then just a little bit further with the commercial payers, if most of them, do you negotiate individual contracts with your commercial payers, or is most of the change as a result of a change in your charge master?
They're negotiated. So year to year, some I might get a 2-year. Again, I haven't even done a full cycle here yet. But we negotiate that generally year to year. And a majority are percent of charges. We have some fee schedules for some hospital-based business. But as you can see from our payer mix, it's primarily government payers, so there's not a lot of volume or business there.
Okay. Thank you. Let's see. This is a bigger picture question, but would you characterize this budget as conservative?
One of your colleagues called me aspirational years ago, which always made me laugh because I am the least aspirational person I know. Nothing goes in the budget that isn't likely or definite.
Okay.
Right. So small hospital, anything, general surgeon leaves, God forbid, everything changes. Right. But I would say it's a conservative budget in the sense that I'm very confident we can hit that number. Short of some catastrophe, we should be able to produce that. I think there is a chance to do better than that with the work we have ongoing. Some of that kind of compounds, it becomes contagious between departments. But what we have with you folks is a historical reputation of not being dependable, good predictors of our outcome, et cetera, et cetera. Hope is not a strategy, and equally, hope is not a budget item. So we made our best estimate on things we were committed to doing as a senior management team, and the trends of the improvements we're making, and that's what I banked on. And I'll be honest with you, I expect to outperform that, but I need to get credibility with you folks too, and not do worse than we say every stinking year that we present to you.
I really appreciate that approach. I do think that the Brattleboro community is suffering the consequences of mismanagement at this hospital. And, I appreciate what you all are doing to change that and change your reputation. I think my last question is just a little bit clarification on the vendors. I did note you talked about your anesthesia vendor and your emergency room vendor. Are they all billing separately for services, or are they billed by your hospital directly?
Their professional services are billed out of their own company. Sorry, Tony.
Okay.
Right, and we do the facility
We do the
charges.
facility charges.
Okay, great. For all of the
For both
provider
the emergency
vendors?
room and the anesthesia.
Okay, great. Thank you. I think that's all the questions I have. I appreciate your time and your thoroughness.
Thank you.
Thanks. And we're going to try and end on time today at 11:30. I know there'll be probably some health care advocate questions and public comments, so we'll try and keep things moving. I just have a couple quick questions. On the outsourced services, such as Blue Water and I think it's called integrative anesthesiology, how much revenue have you outsourced to third-party providers?
I don't know that I can answer that, because that's their billing, and they don't send me they send me a monthly report because their reimbursement offsets our contract costs. Does that make sense? So, I mean, I know generally what they bill, but I don't know what they, and I have a general sense of what they receive, but I haven't really equated it to what historically we were paying when those things were with either another company, in the case of the ED professionals, or when those people were employed, when those positions were employed here. But that's something that frankly is on our list. But they are doing good work for us, and we are very happy with the clinical quality and the working relationship. And not having to worry about the staffing coverage and on-call coverage and all of that is a huge blessing.
Just to provide some historical, anesthesia has, as far as I know, in 26 years, we've never had an anesthesia employed by BMH. It's always been outsourced.
Okay, great.
It's a contract.
Yep.
Before Cheshire, it's a contract.
Yep.
Has there been any review of the outsourced service revenue for purposes of making an adjustment to your net patient revenue? And what I'm getting at is the board gives you an NPR every year, and it has gone up every year generally the last several years. But in at least some of these services have been outsourced, and that revenue should, pursuant to care board guidance, be removed from the NPR number that the board approves. Has that happened?
I guess, I'm sorry, Chair Foster, I don't understand the question. If it's not our revenue, it's not counted in our NPR. Is that overly simplified?
That's correct. But when it comes out of your NPR, when you outsource it, your NPR request to the care board should be reduced commensurate to the amount of revenue that was formerly in your budget.
Yes.
Has that happened?
Yes, it's to the extent that I understand the last 2 years, yes.
Okay. All right, I might send a follow-up on that. In connection with the birthing center and the commercial prices, Can you describe any negotiations with insurance companies to increase the reimbursement for obstetric care?
So we have not spoken to payers. Part of our deep dive was to evaluate what we're being paid by each payer. The difference between the actual literal cost to render a delivery, the gap is so big. It's insurmountable from any payer perspective.
You mean on the commercial side?
On all of it, including the commercial.
Specifically to commercial. Commercial is not reimbursing you sufficiently to provide care for those patients, not like in the aggregate with the cost shift and all
Right.
that, but just as the commercial, they're not paying you enough.
I'm not going to say they're not paying enough. What I'm saying is they are not paying even our cost because our volume has gone down so much. So does that make sense?
Yeah, I think so.
And it's a very small book of business, to be honest with you.
Right, it's a fixed cost of the people, but then a decrease in births, significant decrease in births. 10 years ago, it's 350 births. Last year, 217.
Were there any discussions at reducing some of your high price services, such as imaging, as Member Teachout alluded to increase the reimbursement sufficient to cover the birthing services? So my question is really going to a broader issue we see across hospitals where, quote, a service, quote, loses money, but another one makes enormous gobs of money. And it's, in my view, very volitional what services lose money. You can choose where you're putting your rate, and hospitals have chosen to put it on imaging and labs by and large, and thereby making certain services, quote, losers. Has there been an effort to correct some of the outsized price increases on certain services to make birthing and other services not lose money?
I don't think there's a correlation between those two things, Chair Foster.
Explain.
The birthing center is fixed costs. 24/7 by 365 coverage have to be there whether there's a baby coming in or not. So there's next to zero variable cost in the birthing center. The driver of cost per delivery is how many deliveries are we having. So I could raise my prices by 500%, and Medicaid is still going to pay me a DRG of a flat rate for those services. I may have a pickup in commercial, but it is still not going to cover the cost. I would be disingenuous to say that over the last 35 years that I've been in healthcare, that organizations haven't loaded to pick up the cost shift to subsidize poorly reimbursed departments. That's absolutely happened across this country, no question. That said, I assume that you know this, but there's really like 5 departments in the current environment that post margins. So we don't make money on inpatient, we don't make money in the ED, we don't make money in primary care. We get down the list. So you're talking about 4 to 5 departments that float 28 departments. And right, wrong, or indifferent, that's the reality.
I think we all appreciate that and understand that, but and maybe I'm wrong, and I appreciate your expertise in this, but if you do increase the reimbursement commercially for birthing, even if it's a fixed cost, if you increase the reimbursement commercially to a large degree, there has to be a number where you can cover those fixed costs.
Yeah, it would. Yeah. I mean, I'll do quick math for you if you just give me a second. But it's the delta is so far away, it would be an insane negotiation.
Okay, but the delta on covering the cost of imaging and labs is so far high the other way. Why can't there be a correction so that we can protect the essential services for the community? And I understand, like, I totally understand the fixed costs. I totally understand the volume going down. But as a theoretical matter, it just seems odd that we have such a huge price on these images and such a low, insufficient price on birthing. We somehow got here, and it's through the contract negotiations between insurers and hospitals. Why can't we correct that?
Yeah, it is through historical negotiations. I would, just to get to cost, I would have to increase the commercial payment per birth by $20,000 per birth. And that's assuming all of my birthing center was commercial. And when you think about the fact that it's 40% Medicaid, we haven't had an inflationary increase in 5 or 6 years, and it was woefully inadequate then. We're so far away from that discussion, Chair Foster. I can't imagine sitting down with Anthem and who doesn't like to negotiate anyways, and telling them, hey, listen, I need you to increase your payment to me 600% just for me to get the cost. And it's 5% of my business.
Okay, let me just to probe it, because I mean my job is to probe these things. To get to cost on imaging, by how much would you have to reduce your prices?
Off the top of my head, I couldn't give you that, but I can get it. It's in our cost report. Is a great approximation is available in our cost report of cost to charge ratio.
But there just seems to be a total misalignment between the, trying to protect services, not just as to Brattleboro, but like every hospital. A total misalignment in overcharging in certain areas and undercharging in others that we now are being at threat of losing in our communities. And this is a broader statement for all hospitals and insurers. You need to figure this out. We're not going to accept that these services are just going to be cut because over historically you've added on all this price on images. And historically, you've not added it to these other areas. And I'm not saying that's going to be some panacea that you're going to flip a switch and we're going to solve the solution, but it needs to be part of the conversation as opposed to knee-jerk cut of certain services that, quote, lose money. I'm not putting us all in Brattleboro. It really is sort of a very historical thing. I understand that, but it's a total misalignment of trying to protect essential services. And I think this is just a broad statement that hospitals and insurers need to work on this together. We can't regulate this problem. It's happened because of those private behind the room negotiations, and it needs to be fixed in those negotiations to the extent it's possible.
I don't disagree with anything you just said, but I also want to make sure we're all clear that the government payers are not paying cost. So somebody's got to pay it. And so this goes back to the 70s. I'm almost embarrassed to say that I was there early on. So we've had a series of poorly executed and planned funding mechanisms for 40 years that I can account for. And here we are, to your point.
I will not dispute that. I will not dispute that at all.
Yeah. But in that misalignment would also have to include the government payers. This was a little short where it's almost 50% is Medicaid births. So that would have to increase too, and could be offset. Yes, it could be a restructuring of what's important, what gets value. Women's health then gets value, and you change where the reimbursement goes to. But Medicaid would have to be, it has to be in that discussion also.
I completely agree. And as you all know, I have no control over government payers, none over Medicaid. I'm not disagreeing with your view whatsoever. I think that does need to be part of the discussion as we try and tackle these problems. Just one last question on that. Is there the kind of, I don't understand the nuances of what you're paid from Medicaid. It's just not my area where the Care Board regulates at all. But are you seeing the kind of similar misalignment on Medicaid where you're so under reimbursed? I know you're generally under reimbursed on everything with Medicaid, but are you under reimbursed significantly on, let's say, birthing or primary care and over reimbursed on imaging by Medicaid?
Yeah, Medicaid is a percentage of Medicare, simplest measure. And depending on what services you're running, that could be anywhere from 17 to 38% of costs. I mean, on a typical basis, and again, no inflationary increases for 5 or 6 years. So there's just not, and I kind of round this out. what I have always found terribly ironic, not in a good way, is that if you go to a community hospital and you ask them, tell us your top 5 services that your community needs, right? They need an inpatient bed to go to when they have pneumonia and they're really sick. They need an ER. They need a primary care provider, right? We can argue about the next 2 or 3 probably, but those are the worst paid services in the hospital. And those are the ones that everybody absolutely has to have access to. So clearly we're way off the mark as a system.
Yeah, agreed. Okay, this is really, really helpful, and I appreciate you answering my questions and helping me think about these problems. And I really do acknowledge the tough situation you 3 have all been put in, and rolling up your sleeves, volunteering for this very difficult job, and coming to do this process too. I commend you for the effort. I wish you all the very best of luck in all your challenges, and thank you for the candor and honesty. It's refreshing and helpful to the process. I'll turn it to member Holmes or Merman.
Thank you.
I can go. Thanks. Chair Foster just actually addressed quite a bit of an area that I was pretty interested in addressing. I might just ask a few more questions. I guess one goes to so one of the things that's justified the high prices in imaging in other areas and labs has been the cross-subsidization of areas where you lose money, inpatient medicine, OB. If you end up closing OB, how do you justify the high prices going forward in the other areas?
Currently, I justify it in our current situation because that's not our only loss leader. That we're losing, historically, we're losing money every which way we can, which is not a justification or a rational response, but it's the truth as we sit here today. In my evaluation of this organization, we absolutely have the ability to float ourselves. We've got good people here. We've got a good service line mix. We have great quality. We've got a lot of things, but we've just got to put the pieces together to kind of become more self-reliant and self-sustainable, at which time I will absolutely take a look at anything that is grossly overpaid, because we're in a condition to be able to evaluate those things accurately without hurting ourselves again. So, but with OB goes away, I've got a list of 20 other departments functioning at a loss. So, that benefit gets spread around better, but we're still on the downside of that.
And with regards to that, what analysis of your community needs have you done to figure out that OB is the department to close as opposed to something else? Of the 20.
I don't think that it was that simple, and the doctors can chime in. But what we did know is that it was more. It was a third of our operating loss, and it takes our burn rate as an organization from, whatever 3.5 years down to 1.5 years. So, I mean, the discussion became no hospital or hospital without birthing. Again, no good answer here. Nobody feels good about any of this.
The other part I'll chip in is this, as we talk about increasing access, which is a revenue generator in the primary care or surgery, wherever, increasing births is something we have less control over. There is a hope, again, to Mr. Samuel's point, hope is a tough thing to budget, but there would be a hope that we could increase the births because of the regionalization. But the birthing rate, which is the lowest in the state of Vermont, down in Windham, has just been going down. So how do we increase that access, increase births, becomes quite difficult. Perhaps not impossible, but hard.
Just an anecdote on the birthing rate being the lowest in Windham. I recently looked at the birthing rate in Vermont is the lowest of any state in the country. DC beats us slightly, But anyways,
It's the lowest.
how many more deliveries would you need a year to break even on birthing?
We actually did that math. We actually reverse engineered that, and it was such an unrealistic number. Keene and Greenfield would have to go out of business. And then, basically everybody of childbearing year age having to need our services. It was like literally, I want to say it was close to 500.
I sketched it. I got somewhere in that range, depending upon the payer, 500 to 750 additional. But yeah. So you're asking for a commercial price increase. I think Member Teachout brought up that by our available data, you look like you have fairly high commercial prices. We discussed RVU production earlier, some increase in RVU production, but the production still is fairly low. Have you modeled what it would take in work effort increase for that to offset that price increase?
Yes, I have. I have not gone public with our various work groups in here. I did reference this number in the operational expense management document. We need 7%. I like to deal with simple back of the napkin problems, right? If I can't solve it on the back of a napkin, in theory, I probably can't execute it. So we need 7%. 7% increase in net patient revenue, 7%, this is an or, right? 7% net patient revenue, or 7% in expense cuts, or a combination of those two things adding up to 7%. Additional net NPR comes from either additional volume or rate increase. If we can get to 7%, we can get to break even. Every percentage point is worth 1.1 million. I have a $7 million deficit in the 27 budget. If I can get to 7%, I get to break even. So when we're at break even, then I will use the same math to determine what I can take off the table and still remain sustainable.
So I'm sorry, so could you use a 7% increase in productivity
That's
to
what
get
I'm
to break
saying.
even? Is that? Yep.
It could be, the simplest thing is get a price increase. So if we were in New Hampshire and we were unmanaged, I would be putting in a 7% rate increase on top of the 2.5, and I would be break even next year, and we'd all be happy. But I'm in Vermont, and I already have a pricing problem. So 7% net revenue through access, which I think we actually have the capacity for, in my opinion. 7% in cost reductions, or any combination that adds up to 7 gets me to break even. When I get to break even, I will use the same math in reverse to figure out how I can become more affordable.
So you think you do think you have the access potential to get that 7% through improved access?
We have the capacity. One of the reasons that we limited so we did attrition, right, and vacancies, and we've worked down. We're down 70 FTEs budget to budget. Okay, and so attrition mostly, thankfully, and then we've had a small reduction of force. And the reason we didn't go deeper is because we do have volume creeping up in the clinics and in the outpatient arena. And I want to give it a little time to see if the boats rise to the appropriate level.
Okay. And so I'm going to just do one more question because I know we're trying to get through this. I'm just going to share a quick slide. I don't know if you can see that. So this is from an analysis the Green Mountain Care Board Brown did for the Green Mountain Care Board. And what it is is of inpatient standardized Medicare payments with all the add-on patients for standardized patient. And Maine's at the top, New Hampshire's in the middle, Vermont hospitals. These are just PPS hospitals. The very bottom is Brattleboro, which of the Vermont hospitals has the lowest payment per standardized Medicare case. And you're a Medicare dependent hospital, you're supposed to be getting higher payments, but you're actually getting lower than all the rest of the hospitals in Vermont. And it appears that a lot of that is because you don't have sole community hospital status, which I think is what's driving all this yellow block, these add-on payments above the blue block of the base payment. I just wanted to put up there for a second, because when you talk about potentially being a critical access hospital, I've looked a lot into the critical access hospital cost sharing issue. And it appears, at least from my look at it nationally, that when you switch from a PPS hospital to a critical access hospital, you make more Medicare revenue. But 75% of that Medicare revenue typically comes from cost sharing. Now, that depends on your charges. Brattleboro has pretty high charges. You might even be a little higher than that. So you're really getting most of the money from your community through Medigap plans, a little bit from Medicaid, and a little bit from self-pay and bad debt. But if you were a sole community hospital, you just get a larger increase in that Medicare payment. Now, I haven't done the math at all for you guys, but have you looked at the possibility of a sole community hospital status as opposed to the critical access hospital status?
I think there are 7 possible Medicare hospital models that could be in play in any given location. And I went through each of them to see if we qualified. My recollection is that we did not qualify for sole community. We are a Medicare dependent hospital. We have been receiving low volume add-ons from Medicare as our inpatient volume has dwindled. I don't know if that's counted in that data or not, but it's running us $800,000 to $1 million a year. I'm unfamiliar with your data. I'd love you to send it to me so I could take a look at it and understand it. But we've looked at every one of them, and I'm happy to reconsider and look at anything.
Great. Thank you much. Thanks for doing all of it.
Appreciate it. Thank you, Mr. Merman.
Right.
Think I can
Member
be-
Holmes?
Yeah, I think I'll be pretty quick here. I know we're coming up against time, and thank you all for the presentation. I actually can only imagine the year you've had stepping into this role, and I can't even imagine. I see you shaking your head.
Yes.
Okay. I will recognize that I cannot even imagine the years that you've all had. But I want to acknowledge that, and I can see some, clear efforts here at a turnaround. So it is appreciated. I just do want to ask, if it's possible. It's really hard for us to do a really thorough budget review when the submissions are late and they're still incomplete. And we really do try and do the most thorough analysis as we possibly can. And so in particular, the referrals and visit lag data still looks pretty incomplete. The data on occupancy rates is incomplete. We still don't have the service line supplemental form related to the birthing center. That's really important information for us. So I imagine our team is going to follow up with requests for more complete submission, and I'm hoping that you can turn that around quickly, because we really do look at all of this information and it factors into our decisions. So it's really important. If I could also ask you reference a Kaufman Hall study that was funded by VOS that confirmed many of what you've been finding this year in terms of internal assessments of the situation. Would you be willing to share that Kaufman Hall study with us so we can understand what an external third party is suggesting about either paths forward or how you got into the situation that you got into?
Personally, I don't have any misgivings about sharing that, and it was confirmatory for us. And the work I had done the first couple months here, but I leave it to the acting co-CEOs to make the call on that.
Absolutely, we'll share it. And I also should mention that we are working with Kaufman Hall again to do deeper dives in terms of providing us with benchmarks. We Mr. Merman, to kind of address what you raised, we're continuing to work on our service line analysis, continue to work on productivity. This past year, I would call it the year, if we're being Chinese, the year of finance. This next year is kind of the year of the service line. So we know we're not there. We know we have so much work still to do. I'm just happy the hospital is still in existence, so we can now move forward and do that. So yes, Ms. Holmes, we can provide that to you.
Thank you. That's great. And as you're doing that service line work, I'm wondering, and it would be helpful to understand, and you can do this in follow-up given the time, but how you're defining essential services for your community as you're doing that work. And as I hear you talk about single clinician service lines, and the obvious vulnerability that leaves you when somebody retires or they depart, I wonder if you can, given the time, you feel free to follow up on this, but I'd like to hear about how conversations are going with the New England Collaborative or AHS in your transformation work for thinking about clinical shared service agreements. You talked about shared service agreements around, back office, but fractional specialists that you can share so that you're not, you have more options and you can continue to provide essential services. I'd love to hear what Brattleboro thinks are the essential services that in your mission actually should be retained at all costs for your community. That would be a really helpful for us to understand. I think most people might argue that birthing is that, but I'd appreciate what you all come up with that. But that's a longer answer, and I'd appreciate that follow up as you think about essential services. A quick question I think you can answer quickly. I'd love to hear the most recent, like your current day's cash on hand estimate as of today, inclusive of cash held at the parent, and then also updated projections for year end, inclusive of cash held at the parent.
So combined, we're at 133.4 days cash on hand for the two entities. We're at 60 basically for the hospital. Our bond covenant standard currently is 100. It will be 110 when the forbearance is signed.
Okay. And do you have a projection for year end? That's current? Do you have a projection?
It's going to stay pretty flat to those numbers. We've minimized and deferred capital investments. The AP is stable. We don't expect big gains in the AR in the next 2 months. So I think it's going to be pretty close to that.
Okay. Helpful. And then my last question, we just came in this morning, the cost management plan. I did the best that I could to read it before this hearing, but we're getting materials quite late, so it's hard for us to keep up with all the materials that we're getting. But one of the things that it said in there, you said some employees have been compensated as much as 30% over market, which does seem high. And you talked about, market compensation, market commensurate compensation. You also say in there, unfortunately, the seriousness of our financial situation is not understood, so slowing wage growth will be problematic as it was this year with 7 to 8% increases within 5 months. So you have a situation where you have compensation at above, well over market rates. You have 7 to 8% increases that you've engaged in this year. I'm wondering, labor is your greatest expense. Talk to us a little bit about how you're going to become market commensurate with existing employees that are compensated as much as 30% over market. How are you going to do that?
Yeah, it's a great question. And I'm open to suggestions. One of the phrases that you referenced in there was because we weren't always forthcoming and transparent with employees here, there is an urban myth that has been propagated that our losses are kind of smoke and mirrors and not legitimate losses, which, while we submit to the IRS, Medicare, Medicaid, Green Mountain Care Board, annual audit, they're legit. So part of that is that, people need to understand the circumstances that we're truly in. And then what we've been saying at a lot of meetings is, this isn't going to happen with just a great senior leadership team or a great board. Our way out of this is going to be a village. It's going to be every employee. It's going to be our community. Everyone's going to pitch in. But part of that is getting everybody on the same page as to what situation we're actually dealing with. So it's the most difficult problem we have before us, is what you just referenced, in my opinion.
I'd like to add to that and just say that the executive leadership team took a 10% pay cut. Physicians have not had a pay raise in over 2 years plus. And for this year, senior management and physicians did not get any pay raise.
There was a decrease in CME expenses for.
Right.
um,
We're not paying for
Physicians.
travel for
Travel.
physicians. This is not at the executive level where it's over 30%, just so you know.
Okay.
Also point out that this year did include concluding those 2 union contracts, one with the nurses, the other with the other new union with numerous members in a variety of different roles, both of which had strike votes during the time that we were negotiating, but both were concluded without a strike.
Got it. Okay. Well, you have some big challenges ahead of you. So
Yeah.
I appreciate the work you're doing, and I don't have an easy solution for you, Mr. Sandville.
Well, that's
don't.
what we get paid to figure out. So I will take this moment though to also acknowledge what you just said about our timeliness for filing. Part of that was an extension because the whole OB thing was up in the air, and it felt really disingenuous to the board management to submit a budget without having a decision made on that because it was so material. Additionally, the tardiness, and you've known me for years, and it's usually not my issue, but we went through this budget with really no experience in the Green Mountain Care Board budget development experience. So and frankly, I'll just say that, you know, with all of the activities here, I provided inadequate leadership in that regard. And because we had people who, this is literally their first time doing this, with systems that weren't set up to do this. We've got them set up to do internal now, but they're not set up to produce data. And frankly, some of it, we spent time spinning our wheels trying to figure out how whatever utilization was counted in this department so that we could be consistent with history. So I apologize, and we will absolutely do better. Honestly, we did the best we could. I have done nothing other than this and OB work essentially for the last 3 or 4 weeks. So as have a number of staff members. So clearly not our intent.
I completely appreciate that. You have your hands full, I don't doubt. We'll do the best that we can in reviewing all the materials. So please, to the degree that you're getting requests from our team, I hope that you can comply because it really is important in our analysis. So
yeah,
do the best that you can.
Yeah, they've been great with us, and we've tried to reciprocate to the extent possible for us. We did have data missing from 2022. So one of my mantras is like, I can't keep making reparations forever. So you got to let me, you got to let me move forward, because that's where the solution is. The solution is in the back. So we're trying to be respectful of your needs, but also not take our foot off the pedal in improvement work.
Appreciate that. I'm going to turn it back over to Chair Foster. I know the healthcare advocate may have some questions too. So thank you very much. I appreciate it. And I appreciate the hard work you're doing. I'm sure there's been sleepless nights.
Thank you.
We've been going over 2 hours and we're 10 minutes over. Why don't we just take a 1-minute break here? 1 or 2 minutes. We'll be right back.
Good.
Okay, we can go back on the record, Rebecca.
On the record.
All right, Mr. Peisch.
Good morning. Sam Peisch, the Healthcare Advocate. Thank you to the board, and thank you, Dr. McLarney, Blosson, and Mr. Sanville for all your diligence and directness in answering these questions. I have two categories of questions. One's financials and narrative related, and the other relates to the birthing center. Your most recent outside audit concluded, and I quote, raised substantial doubt about the hospital's ability to continue as a going concern within 1 year after the date the financial statements are available to be issued. You said that it seems like you feel like you're on the right track, but could you respond to that conclusion, which to me alludes to bankruptcy?
So there's a specific definition when the words growing concern are used in audited financial statements. It's entirely accurate and appropriate for them to have put that in our audit. From an accounting, informing the reader of the status of that organization, completely appropriate. That said, we have currently a burn rate of about 3.5 years. So I assume everybody knows what that is. 6 months ago, that burn rate was 3 years. So we are improving, and we are, I didn't come here to fail, and I didn't come here to get a consulting check. I came here because I felt there was something that could be accomplished here that was material and was important. And so I'm confident that that will come off the table, maybe not for this year's audited financials, but we will live to see another year's financials. And I'm confident we can do the hard work to get that thing done.
Okay, thank you for that. In the narrative, you wrote, quote, transactions were unnecessarily complicated, reporting was inaccurate, and transactional processes not well defined for users. As a result, all internal and external reporting was unhelpful and inaccurate in most cases. I want to commend you for the honesty there. I also want to ask, do you feel like you have a clear answer, or the hospital has a clear answer for all the financial discrepancies or misstatements in previous years? I recognize you want to look forward, but I want to make sense of the past and what happened.
So there's no benefit to me vilifying or being disparaging. So I'll limit it to this. How you set up your system. So I'll just talk about general ledger, right?
Yes.
Because we talk about a lot of things. How you set up your system, and I've been on the exact same software in prior lives as this place uses for their platform, is everything. Your implementation is everything. And if you cut and paste from your old system to the new system, you've already made a mistake. So if you don't have things clearly defined before you build it, you've made a mistake. So they did not leverage the assistance that was provided to them when they went live on this. Ultimately, software companies will let you do what they want. They're libertarian. You're going to give me service contract fees every month, do what you want. And they didn't take advantage of all of the functionality available in the new software. So there's software that has belts and suspenders, things like that in there to make things easier, faster, better, and more accurate. And those weren't taken advantage of either. So, death by 1,000 paper cuts in the financial reporting system. I think our first month close took almost 2 months to have 95% certainty that it was accurate. We closed June in about 3 weeks with very high certainty, and we'll see how the audit goes this year, but I think it's going to be part of the deal with our audit last year, and the reason it took so long is because it was difficult for the auditors to do the audit.
Mm.
So I don't know if that answers that or.
Yep. No, that's helpful, and I appreciate. I'm not interested in having you vilify employees. I know that's a tricky balance, but I appreciate your candor on that. I guess in my view, there's also, it seems like you understand there's a role for the hospital board in providing oversight. I'm curious if the board was aware of these problems over the years, and it seems like there's some governance changes that are being proposed, but just candidly, I have concerns about why these deficiencies were not identified over the years.
I think, do you want us to address that, David?
Yeah, go for it. You were here. I wasn't
Sure, yeah,
here.
we were here. We were actually both on the board. So that can give you a little background. We also were both active physician employees who had been asking questions for years. The board also asked questions. As Mr. Sandville said, the data that was generated was not necessarily accurate. So the information that the board received was, I think, different than reality.
Or
Okay.
complete. It was both incomplete and not necessarily accurate. And the word came up before about aspirational.
Okay. Thank you. I want to switch to a couple questions about the birthing center. Are you confident that Vermonters on Medicaid who need labor and delivery services could go to Bay State without getting prior authorization from Medicaid?
It's a conversation right now that's being engaged. You have to realize we're going in two different directions at one time. How do we maintain the birthing center and keep it open and what that entails? How do we prepare in case we cannot do that to have safe off ramps for the pregnant women in the community? So part of one of those conversations, one of those tacks is the conversation between Bay State and Medicaid.
Okay, but so I'm not hearing it clear. We don't know is what you're saying.
Correct, because there has not been confirmation from DEVA as of yet that patients could go to Bay State Franklin.
Okay. Okay. I don't know if you've been listening to the other hearings. It's obviously not your obligation to sit through another hearing. But other hospital CEOs, I've asked them about their birthing services, and some have described it as a quote hill to die on. I'm wondering, I don't dispute, I don't think anybody disputes that rural deliveries are difficult and lose money, but I'm wondering why it's not a quote, if you excuse the phrase, a hill to die on for Brattleboro.
I'll answer that very clearly. Our hill to die on is keeping the hospital open and solvent.
Okay. And my last question, it seems to me that there's this bipartisan consensus of the need to have more young folks move to Vermont and stay in Vermont. I'm trying to reconcile that with birthing centers closing. I don't know how to square that with making Vermont attractive to young families. So but you can choose to respond to that. It's more of a statement, but
no, it's true. We have there's an organization brought up called Next Gen, which is all these community folks getting together and how to increase the amount of young families and people who move to Vermont. Right, we have such an aging population, second oldest state in the country. Windham is one or second or first the oldest in Vermont. And how is the entire group dedicated to how do we encourage young people to do it? This is not helpful for that. It is even less helpful if there's no hospital in town for them to come to.
okay. My last question, it seems like there are only 5 of 28 departments that are margin positive. How do you decide with such certainty that that is the line to close? Is it just the fixed cost piece of it, which I've heard a couple times and I understand and appreciate, but how is that decision made with such certainty, it seems, but not these other service lines are kept open while they're still losing money?
I think it's a combination of the percentage of loss compared to the percentage of patients served. When we look at, and I think team member Holmes brought it up, our community needs assessment. We look at what the community needs. So there's no certainty about this. This is a horrible, very hard decision. It's agonizing, to be quite honest. But we have to look at what our community needs, what our costs are, and what workforce we have to sustain service lines.
If I told you how many hours have been put into this decision, and the communication of this decision, and the cage matches that ensued with, people debating and trying to come up with the answer, and how many hours of sleep have been lost, it's staggering. I'll tell you this, that it is the most time-consuming thing that I have worked on in the last 3 months here. It is a labor issue. It's a community issue. It's in everything. When OB closes, ultrasound volume goes down, OR volume goes down, right? We have to play with all of those. The lab volume goes down. It's so complicated, and the good answer, the easy answer is, hey, keep it open, make it work. But then our burn rate is 3 years or less, year and a half. So no upside here, Sam, none.
Yeah, no, I appreciate that. And I don't ask these questions to be adversarial. I mean, our role at the healthcare advocate is to, advocate for the public. So, and elevate those concerns and think about affordability and access. So, I recognize you're in a different and difficult position. But I'll conclude. I see Member Merman's hand is up. Thank you very much. I appreciate it. Thanks for everything you do.
So, those concerns are being elevated all the time from our community. We continue to get letters, responses, emails saying how important the community finds Birthing Center, which we agree with.
Okay. All right. I really do have a hard stop. I have to get to another appointment. So Dr. Merman, go ahead.
Just a quick question on the burn rate. I just want to clarify my understanding of what the burn rate is, because you'd previously said that the days cash on hand is projected to be stable for the end of the year. I thought the burn rate was the time until you're out of cash.
Yes.
Is that okay? You're projecting stability through the end of the year, but it's a 3.5-year burn rate to zero.
Well, I guess burn rate and stability are not equal. And I don't think I said that we would be stable at the end of the year. We would be in the same place that we're in at the end of the year. But we're running a deficit that requires someone writing a check, which comes out of board designated funds because we're not generating a margin on operations. So those are kind of two related, but not the same.
Hey, Dave, do you mind if we do some follow-up questions? Is that possible?
I'll see follow-up.
I have to get to it.
Yep. That's fine.
Okay. All right. Thanks. I want to make sure the public has some time. Public comment via raise the hand. All right. Well, Dave, I apologize for cutting you off. I was anticipating robust public comment. So go ahead. I got 5 minutes and then I got to run.
That's okay. I think actually follow-up is probably the better place to see this. So thanks. Yeah.
Great.
All right. Great. Well, thank you all very, very much. And I think this birthing discussion is really important. I mean, I think you've done a really good job of explaining all the intricacies and difficulties with the decision. Look, there's when people want to keep a service open, there's often a lack of recognition of the fiscal realities. I mean, the numbers that you gave us on maintaining just for commercial were staggering, admittedly staggering. The volume of increases you need are staggering. I think what people really are clamoring for, rightfully, is what is the broader view statewide and how are we going to do it, right? So that, and I think, my own position is we could have seen this coming 5 years ago at a number of hospitals that they're going to be losers. We've seen the accretion on scanning and imaging and the prices there. And we've seen and known about these losses over here for a very, very long time. And yet across the state, executive teams and boards and management have not been addressing it so that it's not as pronounced as it is now. So some of this could have been done over the last 10 years as we saw this train coming down the tracks. So we are in a bit of a bind and we need to be very, very proactive. And I recognize all the complications that you have all had to deal with. And thank you for doing a good job of explaining to us and everyone else. So we will take a recess until, I think it's 2:30. 2:30. Thank you, Dr. McClarney, Dr. Blofson, and Mr. Sandville very, very much. And we are in recess. Thanks.
Thank you.
Off the record.